So I'm excited to be here today to talk to you about the opioid epidemic. The subtitle From Freud to Fentanyl will become clear in the course of the lecture. I have been retained as a medical expert witness in federal and state opioid litigation, but my opinions are my own. My book was published before I was retained as a medical expert witness, and it goes without saying that I was not paid for the content in this talk today. So this is the material that I'm going to be covering. Basically, I want to talk about the way that opioid prescribing has changed from the 1990s till today. I want to talk about the invisible forces inside and outside of medicine that are driving opioid prescribing, and then finally, what we can do about it. A shorter way to say the same thing is I'm going to talk about what happened, why did it happen, and how we can fix it. So first of all, what happened? Prior to 1980, doctors were reluctant to prescribe opioids because they were afraid that their patients would get addicted to them, and for good reason. This country had seen two prior opioid epidemics, one that started with soldiers using morphine during the Civil War that culminated in the narcomania of the early 1900s when heroin was sold next to Bayer aspirin as a cough and cold remedy for babies. By the way, heroin is just morphine with two acetyl groups added. It was supposed to be the non-addictive alternative to morphine. Remember that theme, it will recur. Then in the Vietnam era, we saw another major opioid epidemic in this country when our vets were coming home addicted to opium. One very interesting thing about that also is a resonating theme, is that when they came back, more than 2/3 of them had a resolution of their opioid addiction simply by being back in the United States where they had decreased access. And then we have our current opioid epidemic, which in terms of scale and impact, in terms of mortality, is unrivaled in terms of any other drug epidemic in this country. Basically, what happened in the 1980s in medicine is that doctors recognized we were not doing enough to help patients with pain. The 1980s was also the advent of the hospice movement imported from Europe, when there was recognition that people were dying in extremis. There was the idea that, hey, let's use opioids more liberally to help people in extreme pain and to help people at the very end of life. In other words, what started out as a very well-intentioned movement inside medicine ultimately gave way to doctors dispensing opioids like vending machines to pretty much anybody who walked in the office and said, I have pain. In other words, there was a Kuhnian paradigm shift inside of medicine where opioids became first-line treatment for minor pain conditions and also chronic pain conditions. They basically became the default to treat pain, period. And it's no coincidence that this epidemic is in sync exactly with an increase in opioid prescribing. So opioid prescribing in this country quadrupled between the 1990s and about 2010. It peaked in 2012. And along with that, we saw a quadrupling in opioid overdose mortality in this country. That is not a coincidence, that is causal. This is a picture that was taken by the Ohio Police Department. How many people in this audience have seen this picture before? Okay, so quite a few of you. These individuals are pulled over on the side of the road in their minivan in Ohio. The two individuals in the front are not deceased. They are unconscious as a result of opioids and their opioid addiction. The woman in the front is the grandmother of the child in the back, and this is her friend. Note the watchful waiting of the child in the background, which really speaks to the multi-generational trauma of addiction. So who's prescribing all of these pills? We'll read a lot about so-called pill mill doctors. These are doctors who are willfully exchanging prescriptions for cash. These are doctors who have lost their moral compass. Certainly, those kinds of doctors exist. They have always existed. But if you think that pill mill doctors are the primary driver of this epidemic, then you have misunderstood it. This epidemic is not the result of a small subset of prolific prescribers. We are all prescribing too many opioids. This is a study that we published in JAMA, where we looked at the Medicare database from 2013 to see who's prescribing opioids. And really the most important take-home message from our study was that, again, it's not a small subset of prolific prescribers driving this, that everybody in medicine is prescribing too many opioids, no matter what your medical specialty. If you look at it by volume, it's internal medicine and family medicine doctors as well as nurse practitioners because there are more of them. If you look at it by specialty, it's pain doctors, which makes sense. But really the bottom line is that everybody in medicine today prescribes too many opioids for minor and chronic pain conditions. This is from the National Survey of Drug Use and Health. The take-home message from this image is that great big yellow circle is the more than 11 million people in this country who misuse prescription opioids. Okay, so we're not talking about heroin, we're not talking about illicit fentanyl, we're talking about more than 11 million people in this country who are developing some kind of opioid use disorder or addiction. Now compare that to this much smaller circle, which is the approximately million people who use heroin. Also a huge problem. But again, I just want to make sure that you leave today understanding that heroin is a huge problem in this country, fentanyl, illegal fentanyl is a huge problem, but prescription opioids are the origins of this epidemic and continue to be a very significant problem. Where are people getting the prescription opioids that they're misusing? Well, what you'll see here is that about 35% get them from a single prescriber. The large section here is those who get them from a friend or family member, many of whom got them from a single prescriber. What this gets at is that whether directly or indirectly, prescribers are the major conduit of misused prescription drugs in this country. This also importantly speaks to something that I've called the tsunami effect. Part of what has driven this opioid epidemic is not just people getting addicted through their doctor's prescriptions, but the huge increase in pills in medicine cabinets across the country that teenagers and other people also have access to. Okay, so that gives you kind of broad brushstrokes of what happened. Where are we now in terms of this opioid overprescribing problem? Well, opioid prescribing peaked in about 2011, 2012, and has decreased approximately 30% since that time. So that is the good news. But here's the bad news. There is still huge geographic variability in opioid prescribing in this country, and we're going to get into a little bit what may be driving that. But just take a look at some of these data. In 2012, in the United States, doctors were writing, on average, 81 opioid prescriptions per 100 persons in this country. In 2017, which is the last year for which we have reliable data, that went down, that's the good news, to 59 opioid prescriptions per 100 persons. But look at the state of Alabama in 2017, 107 opioid prescriptions per 100 persons, a decrease from the 121 opioid prescriptions that were being written in Alabama in 2012, but still you can see we've got a long way to go. Some counties have rates that are 7 times the national average. This is a heat map. The darker red is more opioid prescribing. The lighter is less opioid prescribing. This is when we peaked at 2012. Watch what happens over time. Keep your eye on Alabama and the southeastern United States. 2017, we've made a lot of progress, but we're still not where we need to be. Also, look at this same heat map when you divide it by county. You'll note that even in states where opioid prescribing is relatively low, there are counties where there's a lot of opioid prescribing going on. And if you compare how we're prescribing today compared to the rest of the world, we're still prescribing 3 to 4 times as many opioids as most other developed countries, more than 10 times as many opioids as Japan. And here's an interesting thing. Germany and Canada just switched places. Canada was in second place, now Germany has moved up. One thing we know that's happening is that Big Pharma, an outreach of Purdue Pharma, has now taken its marketing campaign to countries abroad. Also, at the same time that opioid prescribing has been going down, it appears as if benzodiazepine prescribing, Valium, Xanax, Ativan, Klonopin, is going up in this country, along with associated deaths. When opioids and benzos are co-prescribed, the risk of accidental overdose goes up. How do people die from opioids? Well, basically, they fall asleep, they stop breathing, and they don't wake up again. Because opioids slow down the heart rate, they slow down the respiratory drive. When you add Xanax or Valium to an opioid, that increases the risk of that kind of sedation and accidental overdose. This is just one of many typical examples of cases that I have seen in my career. And you'll note this one was in 2017. This was a 28-year-old male. He had a diagnosis of chronic pain. There was no known disease or tissue damage to explain his pain, but nonetheless he had pain from the top of his head to the tips of his toes. And he was on the following regimen prescribed to him by his purportedly very nice, and I believe it, well-educated primary care doctor. 40 milligrams of Opana, an opioid, twice a day, 30 milligrams of Dilaudid, an opioid, once a day, 60 milligrams of oxycodone, an opioid, once a day, 20 milligrams of Valium, a benzodiazepine, once a day, 65 milligrams of phenobarbital, a sedative, 30 milligrams of temazepam, once a day, and no list would be complete without 8 milligrams of Xanax, once a day. So this young man with no known disease etiology other than the endorsement of having a severe chronic pain, which I believe he has, is at imminent risk for overdose death with this regimen. Just to kind of put that in perspective, he's on 470 morphine milligram equivalents daily. The average heroin-addicted person takes about approximately 100 morphine milligram equivalents daily. So all of this prescribed by a doctor, a good doctor, a well-educated doctor, and sanctioned by our modern healthcare system. Now we're in what's been called the second and third waves of the epidemic. What you'll see here is that approximately around 2013 or so, there was a spike in heroin-related overdose deaths. By the way, you'll note here this is prescription opioid-related deaths, which has plateaued. Maybe even gone down slightly, but is still pretty darn high, right? And then you have this spike in heroin, and then right here, synthetic opioids, especially fentanyl, which we know is 50 to 100 times more potent than heroin is. So what happened? How do we understand this? Basically, the first way to understand this is the gateway effect, that essentially Vicodin, OxyContin, Percocet got folks addicted, and the natural progression of addiction is that people look for more and more potent sources and cheaper sources. Price point really matters when people become addicted, and so they've gone from prescription opioids to illicit sources as those became cheaper and more available. Also, partially explaining this is the fact that as we have pulled back on opioid prescribing, individuals can now no longer get the opioids that they used to get from their doctor. Some of those individuals are now going to the illicit market. And then, of course, very importantly, the tsunami effect, right? Just the fact that all of those pills are in all of those medicine cabinets means that for some vulnerable teenagers, they just really have to get one prescription and try it once, and then they're often running to illicit sources. So unfortunately, what we're seeing is that doctors, fearful of repercussions for opioid prescribing in the context of this epidemic, are now no longer being willing to treat some patients with pain. This was a study that was done where there was a Confederate who pretended to be the child of an older person with pain who called a Michigan primary care clinic and said, "Will you treat my father or my mother? They're on this opioid regimen." 40% of primary care clinics in Michigan said, "We're not going to treat your parent. We won't even see them as a patient." So this is part of the repercussion. It's gotten so bad. As you can see here, this is just another example of the fact that many high school students who get addicted to prescription opioids started with a prescription from their doctor. And here's an interesting statistic. In the 1960s, 80% of heroin users started with heroin. Today, if you interview heroin users, 75% of them will tell you that they started with a prescription opioid. Again, a very different phenomenology in terms of this epidemic. Okay, so what I want to do next is delve a little bit more deeply into how this happened. And what I really am going to end up trying to convince you of is that the current opioid epidemic is, in fact, the canary in the coal mine for our faltering healthcare system. That, in fact, opioids became the solution not to patients' problems, but to doctors' problems. In order to really understand how that came about, I think it's important to understand what drives and motivates the compassionate doctor. Because at the end of the day, it's not the pill mill doctor who's lost their moral compass, but the compassionate doctor behind this opioid epidemic. So what motivates the compassionate doctor? Well, first and foremost, people who go into medicine tend to be pleasers. They tend to be people who want to help other people. I would even argue that they're kind of natural codependents. Not just speaking for myself, but myself included. They're also people who are really good at figuring out complex systems, including the school system, to get to the top of their class, to get into medical school in the first place. They're also people who are responding to a higher calling, right? They go into medicine because they want to save lives and alleviate suffering. This becomes a primary motivator for them in their practice. As we go through medical practice, we're very heavily socialized to put ourselves in our patients' shoes, to imagine their suffering. We get very little training on what to do if our patients may be manipulating or deceiving us. And in the 1990s, in addition to there being this paradigm shift in the treatment of pain, this was also the beginning of what was called the evidence-based movement in medicine. This idea that we would eliminate quackery by basing everything we do in data, and therefore we wouldn't have to, it would all be purely scientific. Unfortunately, what happened, which I'll soon show, is that the pharmaceutical industry co-opted the so-called science to convince doctors that opioid prescribing was rooted in science, when in fact there is no science to support it. This is a great quote by William Bruce Cameron, which I love. Not everything that counts can be counted, and not everything that can be counted counts. We forgot about this in medicine. All of a sudden, it became not okay to rely on your clinical judgment, your clinical experience, or God forbid, your intuition. Everybody had to wave a number around. And then ultimately, in order to understand what drives the compassionate doctor, you really need to know that what makes us get up and out of bed in the morning and going to work again and again is that we're going to have that kind of Buberian I and thou encounter with our patients, where we can realize our identity as a healer and our patients expresses gratitude. It's those moments that we really look for. And if we were to challenge our patient about the way that they're taking a pill we're prescribing, it really threatens that mutual affection that is part of how docs get their dopamine. Okay, so let's talk a little bit now, shift about what motivates the drug-seeking patient. For me, what was really revelatory when I first started learning about addiction was to learn something about the neuroscience of addiction and how the brain changes. So what I'm going to do is I'm going to condense like the last 50 years of addiction neuroscience into 3 minutes at a level at which I understand it. It will become immediately apparent that I'm not a neuroscientist, but here we go. One of the most interesting things that we've learned in the past 50 years about pain and pleasure is that they're co-located. So the same areas of the brain that process pleasure are the areas that process pain. And the way that pain and pleasure interrelate is that they work like a balance, okay? So I really like chocolate, so when I ingest a piece of chocolate, my balance tips slightly to the side of pleasure. But here's the thing about the balance. It wants to remain level, and it will work very hard to reestablish a level balance, or what is called homeostasis. And it does that through a process called neuroadaptation. Now, I kind of imagine neuroadaptation as these little gremlins hopping on the pain side of my balance to bring it level again. And that's that moment of wanting a second piece of chocolate, because the thing about the gremlins is they like it on the balance. They don't hop off as soon as it's level, but they wait till the balance is tipped an equal and opposite amount to the side of pain. Again, that's where I'm thinking, another piece of chocolate would be really good right now. If I wait long enough, the gremlins hop off, the balance reasserts homeostasis, and I'm not really craving another piece of chocolate. That's how it works, okay? Now imagine that instead of a piece of chocolate, my doctor gives me some Vicodin. And by the way, I'm in pain, so I'm not even starting out with a level balance, right? I'm starting out tilted to the side of pain. But the balance works the same way. Now I don't get a little bit of shift to the side of pleasure, I get a great big shift. Huge amount of dopamine in my reward pathway. The fundamental difference between substances that are addictive and those that are not is the amount of dopamine that they release in the reward pathway. So now I need a great big Arnold Schwarzenegger-sized gremlin on the pain side to bring my balance level again. But remember, it doesn't stay there. It slams down to the side of pain. That is called opioid withdrawal. It's extremely painful for some people. But you know, it lasts hours to days, depending on how many opioids you took. The gremlin hops off and homeostasis reasserts itself. Now, here is the key piece to understanding the disease of addiction. If I take that opioid for days to weeks to months to years, I have enough gremlins on the pain side of my balance to fill this entire auditorium, right? Because now my balance is working really hard to adapt to all those exogenous opioids. So if I can't get more opioids, if I decide my life is a mess, I want to stop, guess what? I slam down to the side of pain, and it doesn't just take hours or days for those gremlins to hop off. It takes weeks to months to years. And this is what we call craving. I am now walking around with this type of balance. I'm irritable, I'm anxious, I'm depressed, I'm maybe even suicidal, I can't sleep. My life is a lot better. I got my job back, I got my kids back, I got my husband back, but I feel like crap, right? Theoretically, if I wait long enough, the gremlins hop off, and I get a level balance, and I can enjoy a piece of chocolate again. But maybe for some people, that doesn't ever happen, which is where we get this idea that we can use opioids to treat opioid addiction in some cases, and I'll get to that. Okay, so now you understand this physiologic drive that drives the lying, cheating, and stealing, which is a symptom of addiction. So addiction is a lot like other diseases, and in some ways it's not like other diseases because, again, there aren't many diseases where lying, cheating, and stealing are a symptom of the disease, but that's true with addiction. So patients and people who are addicted will do things outside of their moral compass because of their addiction that they wouldn't do if they were not in their addiction. And one of the things they'll do is they'll try to manipulate their doctor for certain types of drugs. I'm going to quickly go over some strategies that I've observed in my clinical experience and interviewing other people in the healthcare profession that patients use very quickly. These are not meant to be denigrating. They're just meant to be illustrative and memorable. There is the senator. These are the patients who use the filibuster technique. They wait till the last 30 seconds of the appointment to ask for a refill because they know it will take you 30 seconds to say yes and an hour to say no, and they're very busy and don't want to get behind in their schedule. The sycophant, these are patients who tell you how much better you are than their other doctor. I used to love to hear that when I was younger. Now it makes the hair on the back of my neck stand up. The exhibitionist, so these are patients who will writhe on the ground, who will undress, very demonstrative displays of pain and suffering. Many of these patients have real pain and suffering, but they will also demonstrate it. The dynamic duo, this is often the patient and a significant other. In my experience, it's the patient and the mother. The mother's crying, the patient's writhing. Very hard to say no to against one. This is the city mouse and the country mouse. So this is the people on the other end of the savvy spectrum. The city mouse walks into the ED, says, I'm allergic to all pain medicine except for IV Dilaudid push with the Benadryl chaser. The country mouse says, well, you know, my friend got something like oxy. I am a natural codependent, so I say, OxyContin. That's right, doctor. I think that, I know how to write a prescription for that. And then the loser, these are patients who will say they lost their prescription, they lost their pills. Water tends to be a common theme here. Went through the rinse cycle, fell in the toilet, went in the bottom of my fishing boat. The weekender, so these are patients that have figured out that we have a very disjointed healthcare system. So they will call in the evenings or they will call in the weekends in order to make sure they get not their regular doctor. The twin, these are other healthcare professionals. They know we went to the same schools, we know the same people. This is my personal Achilles heel, other nurses, other doctors, because I identify with them. And it's hard for me to imagine that somebody who I identify with could be manipulating me. The doctor shopper, these are patients who go around to multiple doctors seeking the same or a similar prescription. And the bully, this is a really tried and true method. These are patients who start yelling, they threaten to sue. At Stanford, they call patient relations. Patient relations calls the doctor, said, we got a complaint. Nobody likes complaints. Okay, so we've talked about what drives the compassionate doctor. We've talked about what drives the drug-seeking patient, namely the disease of addiction. But these individuals are not working in a vacuum, right? They're working in this increasingly complicated healthcare system. What I want to cover now is the invisible forces inside and outside medicine that are driving overprescribing of opioids and other drugs, with this very complex dyad of the doctor and the patient. The first one is the pharmaceutical industry. Big Pharma, opioid manufacturers, opioid distributors, even in some instances, pharmacies, right? This is a huge and powerful supply chain. Everybody knows that pharma advertises right to consumers because it works. Everybody knows that pharma advertises to doctors, hats, pens, lunches, speakers' fees. Even when doctors think they're not being influenced, they change their prescribing. But to really understand the genius of the marketing strategy of the opioid pharmaceutical industry is to understand their Trojan horse-style infiltration of the very watchdog organizations inside of medicine that were meant to protect patients. I'm going to cover it very quickly, but basically, they identified key opinion leaders who they knew would promote more opioid prescribing for minor and chronic pain conditions and propagate their myths. They elevated those individuals' careers and in many instances hired them on as consultants. Continuing medical education, doctors are mandated to attend courses like these to learn about the latest and greatest standard of care, and they subsidized continuing medical education, and they still continue to do that. Professional medical societies, so that's like organizations that are meant for pain doctors or meant for primary care doctors. They subsidize these organizations. Patient advocacy organizations essentially became front groups for the opioid pharmaceutical industry. The Joint Commission, for those of you who are in medicine, you will know the Joint Commission. For those of you who are not, very briefly, this is the organization that sets the quality standards for hospitals and clinics so that they can get the stamp of approval and they can get Medicare and Medi-Cal funding. Without that, you will die as a hospital organization. In 2001, Joint Commission said, you know what? Pain is the fifth vital sign. You have got to ask every single patient whether or not they have pain, and you've got to quantify it because we said it's a vital sign, so it's got to be like science, and we got to put a number on it. So we're going to give you this pain scale, 0 to 10. 0 is no pain, 10 is the worst pain you ever had. You've got to ask every single patient. Turns out using this pain scale does not improve pain outcomes. What it does do, though, is increase opioid prescribing. Federation of State Medical Boards. This is the organization that makes sure that rogue doctors who are hurting patients lose their license. This organization said, you know what, if you prescribe a whole bunch of opioids, you're not going to be in trouble because we know that opioids are safe and effective. And that furthermore, if you withhold opioids from patients in pain, you should get sued for undertreating pain. Undertreating pain. Now, undertreating pain implies that there's good treatment for chronic pain, which it turns out there's not. And opioids isn't the answer. And then again, importantly, this is all part of a huge supply chain that worked in concert. So I've talked about infiltrating science, infiltrating watchdog organizations to propagate myths about opioid prescribing. What are those myths? Let's go through them. And remember here, I'm talking specifically about chronic pain because there is good evidence that opioids work short-term for acute pain. So if you get in a car accident, opioids can be very effective short-term. If you're at the very end of life, the last 2 to 4 weeks, opioids are very effective. There is no evidence to support the use of opioids in chronic pain, which we define as pain every day for longer than 3 months. But here's what Purdue taught us in the 1990s and early aughts when I went to medical school. We now know that many patients with chronic non-malignant pain respond very well to opioids. The barriers to vastly improved treatment for hundreds of thousands of people in pain are simply the misinformation and prejudice of doctors, pharmacists, and regulatory bodies. This is how I was educated, right? That basically I'm prejudiced. I'm harming patients if I don't treat their pain. Here's what the evidence really says about pain. There are no randomized placebo-controlled trials longer than about 12 to 16 weeks showing that opioids work for chronic pain. In fact, what we do know is that opioids know better than Tylenol, and opioids can actually make pain worse because of something called opioid-induced hyperalgesia, which can change pain thresholds. Myth number 2, no dose is too high, no duration too long. That's how I was educated in the 90s. If you've got a patient, they respond, and then they come back and say, it's not working anymore, doc, just go up on the dose. Myth number 2, opioids are effective, easily titrated, and have a favorable benefit-to-risk ratio. Large doses of opioids may be needed to control pain if it is severe, and extended courses may be necessary if pain is chronic. That's how we got to where we are today, tens of millions of patients on extremely high doses of opioids. What does the evidence really say about opioids? Opioids taken in high doses in our long-term harm patients. There is mounting evidence of a dose-dependent risk on opioids. The longer you are on them and the higher the dose, the more likely you are to suffer from constipation, depression, cardiac problems, hormonal problems, breathing problems, addiction problems, and the more likely you are to die from them, even when taken as prescribed. So overdose is kind of a misnomer because a lot of people who die from opioids are taking them just as prescribed. Myth number 3, less than 1% will get addicted, and also this idea of pseudo-addiction. So here was a really, really dangerous myth. Basically, pharma taught us that as long as you're a real doctor prescribing for a real patient with a real pain, there's some kind of magic halo effect that the prescription pad confers that your patient won't get addicted. In fact, if that patient is demonstrating all the signs and symptoms of somebody who's getting addicted, they're not really addicted, they're pseudo-addicted. They're in pain. Just go up on the dose. Contrary to our teaching, addiction is very rare and possibly non-existent as a result of treating such patients with opioids. Pseudo-addiction, appropriate drug-seeking behavior, demanding doses before they are scheduled, vicious cycle of anger, isolation, avoidance, leading to complete distrust. That's not really addiction. You need to increase the dose by 50%. Assure that breakthrough doses are available. Complaints resolve when analgesia is established. Project Tango. This was Purdue's brilliant idea when they decided they wanted to get into the addiction treatment business. They changed their tune. Project Tango was going to be their addiction arm of their business. And then the message was very different. Oh my gosh, opioid addiction can happen to anyone, from a 50-year-old woman with chronic lower back pain to an 18-year-old boy with a sports injury, from the very wealthy to the very poor. Amazing how that happens. What the evidence really says about addiction, 1 in 4 patients taking medication as prescribed for chronic pain will misuse that opioid and develop a mild addictive disorder. 1 in 10 will develop a severe addictive disorder. There's no kind of magic halo effect conferred by that prescription pad. And this is just a timeline showing how long we have known in the scientific literature that this was true. You'll see here in 1996 was when pharma said less than 1% will get addicted as long as you're treating pain and you're a real doctor and they're a real patient. No, wrong, wrong. We've had a lot of evidence for a long time that patients can get addicted even when they're taking it for a bona fide medical condition, even when they have real pain. Myth number 4, dependence is benign and easily reversible. So this is an important point. We have lots of people in this country who are not addicted, but who are on high doses and who are physically dependent and who will struggle to get off. Another thing that pharma said is that, when people get dependent, that's just sort of like normal. That's like, people needing insulin for diabetes, and you just take them off it and, go just taper down over a week and no problem. Turns out, not so much, right? Lots of patients who don't meet criteria for addiction but have been taking opioids every day really, really struggle to get off of those opioids because their body has adapted. Whoops. Dependence is really here's what Purdue said: tolerance and physical dependence are normal physiologic consequences of extended opioid therapy and must not be confused with addiction. Dependence, though, in truth, is no joke. This is a sort of a summary of the literature out there showing opioid-naive patients exposed to opioids in the course of surgery. Look at these numbers, the percentages who will be what's called persistent opioid users a year later. So these are not people who have addiction, but these are people who can't stop taking their opioid. I'm always struck by this one, by Harbaugh. These are pediatric patients, right? So kids who are exposed to opioids because of a surgery, 5% of them, that's a really high adverse health consequence in medicine, will still be on opioids a year later. And these are not medical interventions or surgeries that would require opioids for a year. Okay, what does the evidence really say about tapering-dependent patients? Well, it turns out when you take this population of opioid-dependent patients and you slowly taper them down, guess what? Their pain gets better. To me, there's almost no better proof that opioids make pain worse than that we have people, when you go down, their pain gets better. Now, patients don't believe it when you tell them, and they don't want to go down, but I can tell you from my personal experience and the growing literature, pain gets better when people decrease their dose. Myth number 5, risky patients can be screened out. So here's what Purdue said. Oh, are opioids always addictive? No, watch out for those cherry syrup addicts. Cherry syrup addicts, that refers to people who take methadone maintenance, which comes in liquid form. So that was a very clever move. You know what? There are all those like yucky addicted people over here, but just like screen those people out, and then these wonderful people are good patients. You know, they won't ever get addicted. And the truth is that existing screening tools to separate out people who are more vulnerable or less vulnerable to addiction are really no better than chance. What that translates into is that people with a history of addiction won't necessarily get addicted to the opioids that we prescribe, and people with no history of addiction or other risk factors may get addicted. In other words, we need constant monitoring. We can't just do some paper and pencil screen before we start them, and then we're good to go for the next 10 years. These are the myths of opioid prescribing. I went through all of them. That's the invisible impact of Big Pharma, but let's talk about some of the other invisible forces driving opioid overprescribing. One of them is what I call the Toyotization of medicine. So one of the big changes in medicine in the last 30 years is a mass migration out of physician-owned practice into large integrated healthcare centers. So the majority of physicians today are actually salaried employees. As a result, we practice protocolized medicine, right? We have guidelines, we have protocols, we have algorithms. And what that has led to when it comes to opioid prescribing, there's enormous pressure on doctors to palliate pain, to prescribe pills and perform procedures because that's what third-party payers will reimburse, to protect privacy, and to please patients. We've essentially become waiters, and our patients have become our customers. A couple of years ago, my then 11-year-old son decided to Google my name on the internet. He said, "Mom, is this you?" He didn't seem too pleased about what he had found. And I went over there, and I had this review of me, and you'll note what Corey here had to say at the bottom. I don't remember Corey. She provides the kind of care that will make you wish you had never sought help in the first place. Wrong diagnosis, wrong medication. In some cases, this can be terrible. Seek help from someone else. I mean, I was mortified, of course. You know, my 11-year-old son found that. Who else had seen that? This is a major driver. I've been all around the country in the last 3 to 4 years talking to doctors, urging them to prescribe opioids more judiciously. And they will come up to me and say, "I'll prescribe fewer opioids when you can promise me that I'll still get good reviews on my patient rating satisfaction surveys. Because if I don't, I will lose my job." And this is no joke, okay? These ratings really matter. I can tell you in my job, if I get too many bad ratings from patients, I get called to the table. "What are you doing wrong, Dr. Lembke? What's going on with you and your patient?" In fact, there's no evidence to show that if you get high patient satisfaction surveys, that your patients have better health outcomes. Indeed, this data point suggests that patients who rate their doctors more highly are more likely to overuse healthcare, take more prescription drugs, and die, even when controlling for morbidity. So that's a problem. Now, the good news for me is that my son did come out a few minutes later. He said, "Don't worry, Mom. I just gave you 4 out of 4 stars." Twice. Okay, another invisible force driving overprescribing is the medicalization of poverty. So this has been a really fascinating thing that I have observed in my 30-year medical career. Basically, doctors are increasingly asked to care not just for their patients' biomedical problems, but also for their psychospiritual and socioeconomic problems. But we're not given the tools to do that. So we biomedicalize things that are not, in fact, medical. And then once we've done that, we give a pill. And there's evidence to show that Medicaid, which is the federally funded disability for people who are poor in this country, for Medicaid patients, opioids are prescribed at twice the rate of non-Medicaid patients, and Medicaid patients are more likely to die from an opioid overdose. If you look at this heat map, which you've seen before, remember, darker is more opioid prescribing. Just look at it, get a gestalt from where there's a lot of opioid prescribing, and then look at this U.S. unemployment by county, and you'll see a very similar pattern. So in places where people are economically in trouble, is also the place where there's more opioid prescribing. It's also true that where there are more doctors, there's more opioid prescribing. That's another interesting data point. Another huge change we've seen is this mass migration onto the disability role. So disability is for people who can't work because of medical problems, but essentially disability has become the new welfare. We had 150,000 people getting SSDI in 1957. Main reasons were cancer and cardiac disease. We have over 8 million people on SSDI today. Main reasons are mental illness and musculoskeletal disease, AKA chronic pain. I frequently see patients who are not interested in getting better. They need a certain type of prescription and a certain diagnosis to validate their paycheck because being a patient has become their job, and I don't blame them because it's the only way that they can survive without any other kind of social safety net. Karl Marx said religion is the opium of the masses. We've gotten to a point where now opium is the religion of the masses. You may be familiar with the work of Case and Deaton. They're the Princeton economists who have coined this phrase, deaths of despair. They've shown increased mortality in white middle-aged individuals. Top 3 reasons for death are suicide, alcoholic liver cirrhosis, and drug overdoses. Okay, finally, another invisible force driving overprescribing is new narratives about pain, okay? What we think of in our culture is a tolerable or appropriate amount of pain. And basically, the narrative that we have today is that pain is dangerous. That pain experienced in any form, whether psychological pain or physical pain, leaves a kind of psychic scar that sets us up for future pain. The classic example is post-traumatic stress disorder, but also we have a whole bunch of new chronic pain centralizing syndromes. This is very different from how we used to think about pain, right? This is a very modern concept. In fact, 150 years ago, when general anesthesia was first being invented, some of the leading surgeons in this country were reluctant to adopt it because they believed that pain was salutary. They believed that it boosted the immune response, boosted the cardiovascular response. What doesn't kill you makes you stronger. We could no more say that to a patient today than we could fly to the moon. Oh, we can't fly to the moon, but anyway. Here's a great example of what I'm talking about. This was an individual who walked into an emergency room and he was jumping up and down. He had his construction worker. He had jumped on a nail. He had terrible pain. They gave him boatloads of opioids. None of it worked. Finally, they gave him more and more, and he was sedated. When they pulled the nail out and took the shoe off, they found that it had gone between his toes. Right? But he had this construct of pain in his mind, and we have trained several generations of patients to focus on their pain, to get anxious when they have pain, and to believe that they can't feel better. As kind of a corollary, a very famous study from Beecher, who looked at soldiers on the World War II front and found that these are soldiers who had like gaping wounds, their guts spilling out, their limbs flung a mile away from where they were because of injuries. 2/3 of these individuals had zero pain in the immediate aftermath of their injury. How can that be? Because the meaning of their pain was, number one, they weren't dead, and number two, they were going home. My point here is the way that we talk about pain, the way that we conceptualize pain, has a huge impact on how we experience pain. And in modern medicine, pain is dangerous. Look at what Thomas Sydenham had to say about pain in the 1600s. I look upon every effort and calculated totally to subdue that pain and inflammation, dangerous in the extreme. For certainty, a moderate degree of pain and inflammation in the extremities are the instruments which nature makes use of for the wisest purposes. Today, we don't have narratives like that. In fact, our narrative is the body cannot heal itself, that doctors, especially when aided by technology, have a superhuman capacity to heal anything, and that victimhood is a right to be compensated. So now I hope you have a good idea of what motivates the compassionate doctor, what motivates the drug-seeking patient, the invisible forces inside of medicine that incentivize overprescribing. And then finally, let's look at what happens when that doctor and that patient get in the room and have to have an interaction around the prescription pad. Basically, they're both caught between a prescription and a hard place. This generates anxiety for the doctor. The doctor then enlists his or her primitive defense mechanisms. Just to refresh your memory, defense mechanisms are unconscious strategies, so we don't know we're doing them, that we enlist to dissipate negative emotions, right? Because negative emotions are uncomfortable. Different from coping strategies like I'm going to do my mindfulness breathing exercise now so that I can calm down. That's a coping strategy. The defense mechanism is more primitive. It's actually very adaptive in some emergency situations, but as a chronic coping style, not so much. Here's a common defense mechanism: denial. Like, this isn't happening. I'm a good doctor. My patient's not getting addicted to the pill I'm prescribing. Projection. This is where I take a negative emotion and I put it on the other person because I don't want to own it. So instead of owning that I, as a physician, am feeling rageful toward this patient who's getting addicted, why am I rageful? Because I don't know how to treat addiction because I didn't get trained on it in medical school. I instead project my anger onto the patient. I said, oh, that person has borderline personality disorder. Get her out of here. Splitting, this is where I divide my patients into my good patients and my bad patients. My good patients, those are patients who have really straightforward problems that I learned about in medical school, and they bring me chocolate at Christmas time. Bad patients, addicted patients, patients with complex mental health problems, patients with multi-generational trauma, patients I don't know how to help. And passive aggression, most commonly manifested as procrastination. These are the patients I delay and avoid. They should come back next week. I tell them to come back in 3 months. So what happens when primitive defense mechanisms no longer work? So we have something called the Prescription Drug Monitoring Database. We can go on there and see all the prescriptions for controlled drugs a patient has gotten in the last 12 months. We're now mandated in the state of California and many states as a result of this opioid epidemic to check this database. And when we do, and we see, oh my gosh, I'm the 4th doctor this week this person has seen. What do doctors are doing then? Well, guess what? It's not good either, because then they're experiencing a narcissistic injury. So you do not need to be a pathological narcissist to experience a narcissistic injury. We're all vulnerable to narcissistic injury when our competence is threatened. So whether we're trying to be a good parent or a good doctor or a good bird watcher, when our competence is threatened in that arena, even in a very subtle way, we can experience that core injury, usually unconsciously, and the most common reaction is narcissistic retaliation, where we get angry at the person who caused the injury. And so what's happening, as I alluded to before, is a lot of patients are just getting kicked out of clinics, or doctors are just refusing to treat them. The phrase opioid refugees has been used to describe this population of people now wandering clinic to clinic. And again, this is just an example showing that 40% of these patients are being turned away. There's even an FDA warning that showed that you can't just discontinue opioids in these patients. They'll go into acute opioid withdrawal. Okay, we made it this far. 5 more minutes. How can we fix the problem? Very quickly, we have to stop the pendulum going from enabling to retaliating against this patient population. And we have to do the same thing we would do for any any epidemic, whether it's opioids or tuberculosis: primary prevention, secondary prevention, and tertiary prevention. Just very quickly, primary prevention means trying to limit the number of new cases. Fewer opioid starts, right? Not exposing people to opioids through a prescription for them or to their family members and neighbors and friends through leftover pills. A lot of good work being done in this space. You saw that opioid prescribing has gone down, and that's really awesome. And there's even a lot of really interesting work using local anesthesia and alternative anesthetic techniques during surgeries to limit opioid exposure during surgery, because we know surgery itself can be a gateway to opioid dependency and addiction. Secondary prevention. So this is trying to limit the harm in people who are already vulnerable. So remember, I alluded to that population of people who are dependent but not addicted, who are on very high doses, who are not benefiting, but who are taking them every day. We need to help this population slowly taper down, or maybe all the way off. Remember I said that we have evidence showing that when people get off of opioids, people with chronic pain, their chronic pain actually gets better. But we're making a really big mistake with this population. We're just cutting them off, which isn't helping them. Or we're going down too quickly. I have patients on year 3 of their opioid taper because it's a really painful process. And they need a lot of support, and they need a lot of coaching. They need alternative treatments for pain. Insurance companies have to pay for it. And a lot of them need, a mental health treatment also. And then tertiary prevention, treating cases, right? We have to treat the people who have become addicted. We have to use all the tools in our toolbox. I know when I first came to this work, I was really reluctant to use medications like buprenorphine or methadone maintenance. These are opioids. I didn't want to just be giving opioids to people who are opioid addicted, but guess what? There's a lot of robust evidence across continents and decades showing that opioids, special opioids that have special properties to treat opioid addiction, decrease the use of illicit opioids, stabilize well-being in people's lives, decrease transmission of HIV and hepatitis C, and improve overall quality of life. So really, really important that we not outright reject that, even though on some instinctual level it's uncomfortable to think about giving opioids to people with opioid addiction. And then obviously we have to do a lot more around these invisible incentives that are driving opioid prescribing, right? We have to make sure that insurance companies pay doctors to spend time with patients, to talk with them, to provide non-opioid alternatives to the treatment of pain, to provide mental health treatment. And we have to do a much better job educating doctors about addiction. I didn't learn anything about addiction when I went to medical school. Even in my psych residency, learned nothing about addiction. Who taught me about addiction? My patients did. When one of them almost died because I was clueless and never even asked her about her addiction. I'm going to stop there. Thank you so much.